So let's go ahead and take a look at the anatomical layers of the skin. We have three distinct layers that we're going to be looking at. We'll be looking at the epidermis, the dermis, and then the hypodermis. Within each one, we'll go ahead and look at specific structures that we'll find within them and the overall function of each of these layers. So the first layer that we're going to look at is the epidermis. The epidermis is made up of stratified cuboidal and squammal epithelial cells. It lacks blood vessels as we get away from the deepest layer, or stratum basale. The stratum basale is a rapidly dividing layer of epidermal cells. As we move more superficially, because of the avascularization, the rate of diffusion of materials into those tissues becomes very slow relative to the metabolic rate of the tissue itself, or of the cells themselves, which leads to the misnomer that the epidermis is a layer of quote unquote dead tissue. It's not dead, it's just it takes so long for the tissues to get any of the available materials to it that it cannot metabolize them fast enough. As we get to the stratum corneum, however, because of the change of protein arrangement within the cell itself is metabolically dead at that point in time, which point in time is referred to as being a completely keratinized cell. This keratinization of stratum corneum is what actually develops the barrier between the body itself and the external environment. The cells that make up the epidermis are referred to as keratinocytes. And the reason why I call them keratinocytes is because the protein that we see within them is predominantly going to be keratin. On the lower layers of the epidermis, they're held together via a tight junction. However, as we move through stratum granulosum and into stratum lucidium, we kind of start changing that junction points. And the change in junction points goes from being a tight junction to being more of a desmotic junction. And this desmotic junction becomes more pronounced when skin becomes damaged due to excessive ultraviolet radiation, which we'll talk about when we look at adaptations. So when we look at the layers, we have distinct layers, or we refer to as strata, of the epidermis. The deepest is stratum basale, and the most superficial is stratum corneum. In between stratum corneum and stratum basale, we have three distinct layers. Just superficial to stratum basale is what's referred to as stratum spinosum. Now, if you notice, there's a change of structure within the cell arrangement, so you start seeing these kind of little spikes. That's why we call them spinosal cells, or stratum spinosae. The stratum spinosum, in what's referred to as thick skin, tends to be much more robust than what we see in thin skin. This stratum spinosum is going to allow for some compressibility within the epidermis. It's also going to lead to the callousing that we'll see in skin that has excessive frictional damage to it. As we move superficial from stratum spinosum, we start getting a change of arrangement of cell structure as we start to become more of a squammal shape within the stratum. This change also is occurring with the pronouncement of granular vasicles within the epidermis. That is stratum granulosum. This stratum granulosum is where we will start seeing pigmentation take place. And the principal pigment that we see within here is the pigment melanin. This pigment melanin is being produced by secondary cells within the epidermis, the melanocytes. Superficial to stratum granulosum, we get to what's referred to as stratum lucidium. In stratum lucidium, what ends up happening is we start to lose that granulation. The granulation starts to get lost, and as the granulation starts to get lost, we start having this translucent layering of cells. The translucent layering of cells is due to the alignment of the keratin proteins, where they are all in parallel with each other, so light is able to pass directly through it, hence the term lucidium. As we move to the most superficial, we start getting to the stratum corneum. In stratum corneum, what ends up happening is that due to exposure to ultraviolet light, we start getting cataracting of the proteins. The proteins start to change their shape due to denaturing. And as they change their shape due to denaturing, what ends up happening is that we start having an opaquing of the cells, which means that light is not able to very easily get through. And that is why we have more of the skin tone that we have in terms of coloration. The principal coloration that we're seeing, however, is coming from the melanin itself. If we were to take a look at the same schematic in terms of a histological slide, this is what we're looking at in terms of the nature of the tissues. And so notice how large stratum spinosum is relative to both granulosum and lucidium. And then notice how stratum corneum once again starts to become more pronounced. This layering of cells is what's going to slow down the rate of diffusion through the epidermis and thereby provide the protection that is necessary for the body through the integument to the external threats as well as to internal threats of loss of excessive fluids. Within the epidermis, we have a couple of supports that come into play. One of them is going to be linked with immunological functions. The other one is going to be linked, as we talked about previously, in terms of skin pigmentation. So the first one we're going to look at here is the melanocyte. The melanocyte is going to protect deeper tissue from ultraviolet light by secreting the protein melanin from projections known as pseudopoda. So the melanocytes themselves sit at the dermal papillae, and then they project cellular structures known as pseudopoda up into the granulosa layer, at which point in time they kind of spread out in between the granulosal cells themselves. As it goes out into the granulosal cells themselves, they will start to release packets of melanin. Those packets of melanin will be absorbed within the granulosa layer and leads to the pigmentation that we see within the integument, within the skin. This pigmentation is there to protect from ultraviolet light, and it's basically a cost benefit analysis the body's making because we do need some ultraviolet light in order to synthesize active forms of vitamin D. And so what the melanocytes are doing is ensuring that we get enough UV radiation to allow for the change in Vit D without so much UV radiation that we have ionizated oxidation of DNA that leads to the cancerous growths that are usually referred to as skin cancers. And we'll talk more about that when we look at the adaptations. The other type is what's referred to as the Langerhans cells. Langerhans cells are embedded macrophages that function as immune cells within the integument, within the skin itself. They're usually deep within the stratum passae. They are going to be instigated when we have any type of epidermal injury that gets down through the upper stratus, through the more superficial stratus and down into stratum passae and stratum spinosum. They're going to trigger a nonspecific immune response or nonspecific immune defense, which includes inflammation. That leads to fibrotic changes and scarring of the areas. It's these Langerhans cells in combination with the melanocytes that leads to the change of pigmentation that we see with tattooing. And the reason why we want to limit the amount of ultraviolet radiation to areas where we happen to have the tattoo ink is we want to make sure that we do not change the arrangement of the melanocytes within the fibrotic nature of the Langerhans response to the damage from tattooing. And we'll get more into that when we discuss some of these issues during online time.